You're listening to Quality Talk, a podcast from Primaris Healthcare. Quality Talk focuses on healthcare quality improvement with an emphasis on the value-based care environment, reimbursement demands facing health systems, practices, and clinicians. Quality Talk also, from time to time, delves into patient safety and other related topics. Hi, I'm Jody Jackson Jr., host of Quality Talk. Quality Talk also features healthcare leaders and newsmakers. Some of our past guests have included NAHQ's Stephanie Mercado, ASCO's Monica Bertignoli, Dr. Sunil Dand, who is an incredible blogger and speaker. And we've also spoken with the Director of Quality for the Ramsay Health System, which is the largest non-public health system in Australia. And we mentioned that one because that dual episode continues to be among our most listened to episodes. This episode is the first of 5 Quality Talk episodes that looks at the American Heart Association's Get With the Guidelines Stroke Program and Registry. So let's get to know Get With the Guidelines Stroke. We'll call it GWTG. And the Joint Commission Comprehensive Stroke. Both of these are clinical registries. But let's get the setting for this a little bit to understand that time and action are really critical, even more so than most other medical emergencies when an individual has a stroke. It's also important to understand the urgency and complexity of all the data that begins to flow to medical charts and electronic health records, because the data will help healthcare teams make the best treatment decisions while also populating registries that are integral research tools. This research gives clinicians and health systems and folks in the value-based care world, it gives them a good look at how populations of patients are receiving their treatment in terms of timeliness, effectiveness, and ultimately the outcomes and the cost. But first things first here with the guidelines, getting the patient to a hospital, preferably an accredited stroke center, as quickly as possible for treatment or for clot-busting drugs to be administered. Time is of the essence, and you're not learning anything new from that. But most times, EMS services bypass non-stroke centers to find a stroke center if there's time. And even then, hospitals that aren't recognized as Joint Commission certified stroke centers often transfer stroke patients to a facility that is. As an officially designated stroke center, the facility has already sustained and, achieved excellent scores for quality measures. They've got a 24/7 neurology physician coverage, definitely a requirement and an expectation for stroke centers. And that makes the facility stand out even more. The distinction earned with the Joint Commission Comprehensive Stroke Measures is obviously outstanding. Now, the American Heart Association's Get With the Guidelines Stroke Registry should also be a key element in your stroke center's operational focus. GWTG adds additional layers of recognition, prestigious awards, as well as a public image that can benefit hospitals when it comes to things like recruiting physicians and, for the public, giving patients a clear choice based on proven quality. Plus, we know that insurance companies like to work with hospitals that have better patient outcomes and proven, documented, data-driven results. In addition, Get With the Guideline provides resources, research, and training to clinicians and to the staff required that's being asked to provide abstracting charts and data for the Get With the Guidelines registry. Now, to make the distinction between the Joint Commission Comprehensive Stroke and Get With the Guidelines Stroke, consider this is an oversimplification, but think of it in this way. The Joint Commission Comprehensive Stroke Registry is mostly system-facing. It looks at processes within the system, there is some overlap and similarity with Get With The Guidelines. Well, but Get With The Guidelines stroke is more about patient-facing interactions with and quantifying and qualifying encounters with patients. Those observations aren't intended to diminish or undermine the Joint Commission's program. In fact, the Joint Commission helped develop the comprehensive stroke measures in collaboration with the American Heart Association, the American Stroke Association, and the Brain Attack Coalition were also involved there. There are other complex logistical and operational differences. For instance, Get With The Guidelines stroke measures and specifications can sometimes get a tweak or an additional measure on a monthly basis. The Joint Commission Comprehensive Stroke is typically more static, yet changing to some degree every, say, 6 to 12 months. I understand from speaking with our quality data services team at Primaris, I think it was last week, we're talking about mid-February 2020 here, there were already some changes for the following month and in months that are coming up. So specifications change frequently, and that's an extra challenge to health systems and to the staff responsible for doing the data abstraction within your practice or your facility. For a list of measures currently in place for discharges January 1 through June 30, we're talking about the Joint Commission registry here. We provide a link to that on our website. We'll provide a link to that in the show notes for this episode. And both the Get With The Guidelines and Joint Commission stroke registries are among the most complex when it comes to medical chart abstraction and gleaning data from electronic health records. Among the measures that are included for performance achievement awards from Get With The Guidelines, and probably should have backtracked a little bit, Get With The Guidelines provides very significant awards that help boost a hospital or stroke center's public image and standing in the community, but also it's proving quality care. So it's not just a matter of saying, hey, we've checked off these boxes or we've reported this data, but it's been meaningful and it proves quality. So some of those measures for those achievement awards, and we're going to talk a little bit more about the measures. We're not going to dive real deep into those weeds, but we're going to give you resources and contacts for folks who can have those conversations with you. So some of the measures included for performance achievement include IV tissue plasminogen activator within 3 hours, or if the symptoms of onset to door is within 2 hours. The use of antithrombotics, timing of antithrombotics, anticoagulation for atrial fibrillation, deep venous thrombosis prophylaxis, low-density lipoprotein, and there are certain measures and parameters for each of those. And we also talk about statin treatment for patients and smoking cessation counseling, among others. Now, Joint Commission comprehensive stroke measures either differ from or are sometimes called something different from Get With The Guidelines measures. In addition, there are many types of strokes, different treatments, medications, and methods of documenting it all in the EMR and the medical charts. And the reason that we're making these distinctions, and especially explaining the complexity and the need to keep up with changing specifications and so on, and even the different use of terminology for some of the common, what we might think is a common term. We bring all that up to wrap it into the notice that this is really tough to do for your staff in-house. Unless they are specially trained, unless they have the time to do the abstraction work, and if they have time to keep up with all these changing specifications. So stroke center staffs that provide patient care while also being responsible for chart abstraction may benefit from partnering with an outside expert in stroke registry data abstraction and reporting. One of the constant themes at Primaris is that Primaris takes care of your data. That lets you take care of what matters most to you, your patients. And from that aspect, Primaris is your partner in healthcare quality. So let's take another quick peek at some of the more about the measures here in Get With the Guidelines, as well as Joint Commission Comprehensive Stroke. The AHA's stroke measures and registry is obviously not just a checklist to mark and send in. That's also a very common recurring theme in quality talk episodes, where we talk about value-based care, healthcare quality, and quality improvement. We talk a lot about how this isn't just a list, just a sheet that you check off a box, say, okay, we did that. Because ultimately the data needs to be meaningful. That's a term, of course, that the feds came up with several years ago. They talked about making sure you have meaningful use of the of your data and of your electronic health reporting system. But if it's not useful and if it's not meaningful, then you can't take action on it and improve patients' treatment and lives. So that is really the ultimate test of your quality care. It's not checking a box or marking off a list. It's proving that your patients are receiving better, higher quality care. Now, the data does continue to show that Get With the Guidelines is closing the gap and improving, for instance, the door-to-needle metric. That's the one that's often considered the top measure for stroke response treatment and care. Also on our website with the show notes for this episode, we're going to provide a list of about 8 different measures from the Get With the Guidelines program. These achievement measures are embedded in the proprietary patient management tool, and that is a tool of the American Heart Association's. And one of those, and it is similar to what the Comprehensive Stroke Joint Commission Registry measures and tries to quantify, is VET prophylaxis. The patients percentage of patients with ischemic stroke, hemorrhagic stroke, or stroke not otherwise specified who receive that treatment the day of or the day after hospital admission. Mention smoking cessation. What percentage of patients with a stroke or a TIA with a history of smoking cigarettes who are or whose caregivers are giving smoking cessation advice or counseling during a hospital stay. Corresponding measures are also available for observation status only and inpatient stroke cases. Something as, I'm not going to say as simple as smoking cessation, but when we talk about, well, have they been advised? Has there been a conversation? A lot of times you would think in your practice, well, yeah, we had that conversation. Physician might say, yes, I asked my patient about that, or the nurse might say, yeah, that was part of the intake. I asked about that, but was it documented? And was it documented in the right place, either on the medical chart or in the EMR? So it's one thing to go into the nuts and bolts of measures, but sometimes it is as simple as, and again, it's not simple, but the quicker fix might be simply a workflow issue. Are the questions and the answers being documented? Because you need those when you go back to do the abstraction and to do reports for these and other registries. Comprehensive stroke, number of measures there that the Joint Commission has already adopted for the first 2 quarters of 2020. And that includes hemorrhagic transformation, timeliness of reperfusion, an arrival time to skin puncture, door to needle. And, again, that's an example of how there's different terminology. We call it door to needle. We call it time to skin puncture. So there's a lot to learn, a lot to know, and Primaris is in a great position to give you a hand there. And thanks for listening to this episode of Quality Talk. That's all for now. You can find the show notes for this episode with links to citations and other resources that I've mentioned here. You can find that at www.primaris.org. Also, feel free to send your comments, questions, and your suggestions for future episodes. Send them to me at jjackson@primaris.org. Thanks again for listening, and remember, Primaris takes care of your data so you can take care of what matters most, your patients.